Hello everyone. Now I'll be discussing questions of diabetes. We have a 67-year-old male, 12 years history of type 2 diabetes. Patient come to you with burning and stabbing pain in his feet for the last few months. Pain is very severe enough to interfere with the daily activities and worse at night. Well, as far as the medical history is concerned, hypertension, hyperlipidemia, coronary artery disease, and he had a non-ST elevated MI also 5 years back. And treatment is Glargine, Aspart, metoprolol, valsartan, atorvastatin, and aspirin. There is loss of ankle reflexes bilaterally. There is loss of vibration sense and altered proprioception below knee. Hemoglobin HbA1c is 8.7, and as far as creatinine is concerned, it's fairly in the normal range. Now, in addition to optimizing the glycemic control, which the following is the most appropriate medication for the management of current symptom? Remember, his current symptom are problem of the pain and burning sensation, especially at night. The best answer of this is pregabalin is the best out of this. Why this is the best? Why not others? Let's learn in detail. Well, now in this patient, the patient has uncontrolled diabetes, elevated HbA1c of 8.7%. And the patient has neuropathic pain, burning and stabbing pain. Point to be noted, this what is written is neuropathic pain. In diabetic, the problem is due to nerves. It's not a somatic pain. It's a neuralgic pain or neuropathic pain. We also write it to be neuralgic pain. Well, as far as sensation is concerned, these distal neurological deficit are there. Symmetrical problem occur in diabetic patient. In our patient, loss of reflexes, bilateral ankle reflexes are lost. Altered vibration and proprioception are there, and we know very well these two sensations, that is vibration sense and position sense, they are carried by the posterior column. Okay, so we are very clear about it. The patient is having sensory motor polyneuropathy due to diabetic mellitus. Now, the clinical feature of diabetic neuropathy include, depending on what type of nerve fiber are involved. We know in the basic anatomy that there are two types of fiber, the small fiber and the large fiber. So now if small fiber neuropathy, this predominantly leads to pain. Anodynia, absence of pain in the previous painful region, like this patient in our question having lot of pain. Maybe after some time the pain disappear, but sensory loss will be there. Then we call it the word as anodynia is there. Okay. Paresthesias, burning, numbness, itching, hyperesthesia, increased sensitivity, tingling or with no apparent cause. This is idiopathic. We call it to be we use the term as paresthesia. We don't have any reason, but we are getting lot of numbing and paresthesia. We call it to be paresthesias are there. Now, as for large fiber involvement, they lead to numbness, loss of proprioception, diminished vibration sense, and loss of ankle reflexes are seen. All are due to large fiber. Okay, so these all can happen in long-standing diabetes. They are not acute problem. They occur in long-standing diabetes for at least 8 to 10 years. Well, both types are commonly seen in together. It's not that only isolated small or large will be there. It's not like that. Both can be seen together. A diabetic neuropathy progresses, the pain may diminish, but the sensory deficit persists, the point I already mentioned to you in the previous slide. Well, initial treatment for painful diabetic neuropathy include, so we can include following group of drug. Then we analyze which is the best. We can use tricyclic antidepressant like amitriptyline, which is again there in the choices. We can use dual serotonin norepinephrine reuptake inhibitor like duloxetine, or we can use anticonvulsant like pregabalin and gabapentin. So they are the group of drugs that we can use. Let us see what do we use in our patient. Now, pregabalin is a structural analog of GABA. And we know very well GABA, it decreases pain by inhibiting release of excitatory neurotransmitter by binding to voltage-gated calcium modulator on nerve terminal. Okay, so it's a type of, has a GABA-like action. Well, what are the common side effects that we'll be having with pregabalin? Drowsiness, weight gain, and fluid retention are some problem. Okay, well, now I have a question for you. Now, this fluid retention can occur with pregabalin. Now, write down the answer in your copy. Tell me which anti-diabetic drug can also lead to fluid retention. You can stop the video, write down the answer in your copy. Well, the answer is pioglitazone. Especially what we use is pioglitazone. They are notorious. So that's why pioglitazone should not be used in patients with cardiac problem like congestive heart failure or hypertension. They act on the they act on the PPAR gamma receptors. Okay. So now we'll talk about basic concept of various drugs that we use. Then we'll discuss the answer. I told you we use tricyclic antidepressant, amitriptyline and nortriptyline. How they act? They decrease reuptake of serotonin and norepinephrine. And that lead to inhibition of the pain signals. Okay. Anticonvulsant like gabapentin and pregabalin, they decrease depolarization of neuron in CNS. The point I mentioned in the previous slides. Opioid, they lead to activation of central opioid receptor and they are analgesic. Capsaicin, it causes loss of membrane potential in nociceptive fibers. It is usually used as a topical. Lidocaine, again topical, they decrease depolarization of neuron in peripheral nerves. Okay. Now, amitriptyline, which is a very good drug for this type of pain, but is not to be used in this patient. Reason being, although amitriptyline is effective for reducing pain, but they should not be used in above the age of 65 years. Our patient is of 67 years. Because of anticholinergic action, they can cause urine retention. Already our patient is a 67 year, they will have problem of BHP in males, and due to other reason in female also they may have a lot of urinary problem. So we don't want to use this type of drug in elderly people. Of course, due to anticholinergic action, they can lead to constipation also. So in elderly people, it's not a drug to use. It should not be used in patients with pre-existing cardiac disease due to risk of precipitating conduction abnormalities. So one more reason why not to be given in elderly people. Ketorolac is a type of non-steroidal anti-inflammatory drug that we use for somatic type of pain, joint pains. And I told you in the very beginning, in case of diabetic neuropathy, it's a type of neuropathic pains. It's not a somatic pain, and these drugs are not very effective in neuralgic pains. And they are contraindicated in patients on antiplatelet therapy for coronary artery disease and those with renal insufficiency. The patient already taking low dose of aspirin, it should not be added, and of course, especially in case of patient with conjugate in renal failure, they should be avoided. Oxycodone is a type of opioid. They are effective for painful diabetic neuropathy, but their effectiveness is limited and they are not recommended due to initial treatment because they can lead to dependency in later stages of life. So it's never the first line treatment, but effective, but not the first line treatment. Finally, prednisolone, systemic steroids, they are not used in diabetic neuropathy. They are not a drug to use. And moreover, when we use prednisolone, they are going to worsen diabetes. They are going to increase diabetes. Hyperglycemia will be there. So rather, it is a steroid are contraindicated in any case of diabetes. Now, I have a question for you. Tell me which diuretic can worsen diabetes. Stop the video, write down the answer in your copy. Okay. Answer is thiazide. So thiazide should not be used in diabetic patients. So golden line to remember: initial treatment for painful diabetic neuropathy include tricyclic antidepressant like amitriptyline, but they should not be used in above the age of 65 years. Dual serotonin norepinephrine inhibitor or reuptake inhibitor like duloxetine, anti-conversion like pregabalin, gabapentin. Pregabalin decrease pain by inhibiting release of excitatory neurotransmitter. Okay. Thank you very much.